And we will get started in just a moment. All right, thank you for joining us today for the first webinar in our Ohio Pediatric Psychiatry Access Line webinar series. Today we are going to discuss how to incorporate OPPAL, as we lovingly call it, into your primary care workflow. Today's session will be recorded and you will receive a link to the slides and the recording.
It tells me 32. You don't have 32 A1C machines.
Just a reminder to please make sure you are on mute if you are not presenting. Thank you to our project sponsors, Ohio Department of Health, Ohio Department of Medicaid, Ohio's Medicaid Technical Assistance and Policy Program, and Ohio's College of Medicine Government Resource Center. A few housekeeping items. Please stay on mute to minimize background noise. We will be monitoring the chat for questions, and we'll also have some time at the end for questions and comments. Please remember to turn on closed captioning if you would like. And I should have mentioned, my name is Kristen Fluitt. I'm the Senior Quality Manager at the Ohio chapter of the American Academy of Pediatrics. And we are hosting today's webinar and very excited for your attendance. I just wanted to read this disclosure statement that we have. The Health Resources and Services Administration, known as HRSA, Department of Health and Human Services, provided financial support for OPPAL. You can read the additional information about the amounts of the awards. The content of today's presentation are those of the authors, and they may not reflect the policies of HRSA or the U.S. government.
On it? Okay. Cool.
Just a reminder, if you would, to please make sure you are on mute if you are not presenting. And we are very grateful to our presenters today, Malachi Amini and Dina Thurman. They will both introduce themselves once we get further into the presentation. Another disclosure: the planners, faculty, and others in control of content, either individually or as a group, have no relevant financial relationships with ineligible companies. And the presenters have all considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is their intent to foster respect, belonging, support, and accountability. If you have any concerns or comments, please contact Dr. Kelsey Logan at the email address on the screen. For today's objectives, you will be able to describe reasons to use OPPAL, describe a typical clinic workflow utilizing OPPAL, understand trait workflows related to OPPAL cases. I'm just going to make sure we still have a few people in the waiting room. So just to review a bit, we wanted to make sure we talked about what OPPAL is. And it is a long title, which again we refer to as OPPAL, but Ohio Pediatric Psychiatry Access Line is a telephone helpline that provides primary care clinicians with same-day, convenient, peer-to-peer consultation with a child psychiatrist. Additionally, the program provides educational resources for pediatric primary care clinicians to help support the essential behavioral health care work they do every day all across Ohio. The consultation line also assists and supports Ohio's pediatric primary care providers with resource assistance for patients that require behavioral health outside of the pediatric medical home. We do have the website there for you, and again, you will receive all of that information in follow-up. Hopefully you've already visited the website. There's some great resources. And again, just to review a bit of an overview, child and adolescent psychiatrists are available for telephone consultation from 9:30 a.m. to 4:30 p.m. Monday through Friday, except for federal holidays. Consultations are available to pediatric clinicians with prescribing authority and eligible patients from age 0 through 21 years. Ohio's children's hospitals are sharing the responsibility for staffing the consultation line. And as you can see at the right, there is the schedule for each weekday. So Mondays is University Hospital Rainbow Babies and Children. Tuesday is Dayton Children. Wednesday is Akron Children's. Thursday is Nationwide Children's. And Friday is Cincinnati Children's. So we have a poll that we wanted to do just to see kind of where we are in terms of registrations with the OPPAL. So I'm going to launch the poll, and if you wouldn't mind, you should be seeing the poll now. There are 2 questions. The first is your practice enrolled in OPPAL? So please select yes or no for that. And then the second question is, which type of OPPAL marketing piece would you prefer to receive? If you do select the other option, please make sure you type into the chat what that might be. So these are ways for you to sort of share OPPAL and information about OPPAL with others. What do you think would be most helpful? So again, is your practice enrolled? And then which type of marketing piece would you prefer? So it's looking like we probably have over half of the folks on the webinar as practice enrolled in OPPAL, and that's wonderful. And then flyers seem to be at the top of the list, with posters and magnets sort of in second place. So I will end the poll, and then again I can share the results. All right. And we will move on to the next slide. And with that, I will turn it over to Dina if you would like to introduce yourself, and then you can get started.
Great, thank you. All right, well, good afternoon, everyone. So I am Dina Thurman. I'm a pediatric nurse practitioner at Dayton Children's Hospital. I've been a nurse practitioner for almost 25 years. I've worked in a variety of settings, including primary care, urgent care. I worked in our Department of Child Advocacy at the hospital. And most recently, for the past 4 years, I've been running our hospital's only school-based health clinic. And so I am going to share with you kind of my experience in using OPPAL and looking at those poll results. It looks like about half of those on here are enrolled and half are not. And I want to strongly encourage all of you to enroll. It's been such a wonderful resource to me in my current practice. So this is kind of my why we should be using OPPAL. You see there in the first bullet that it provides real-time guidance for mental and behavioral health concerns. You know, as primary care providers, we are often the first point of contact for children with mental or behavioral health needs, but we may not all have immediate access to specialists. OPPAL gives us that real-time expert guidance when we need it. This also reduces treatment delays. As many of us know, without this program, families can wait months sometimes for specialty care. And with OPPAL, we can begin appropriate management. We can make referrals and do appropriate evaluations right away. OPPAL, while it doesn't replace the need for our specialists, it does empower us as primary care providers. Over time, as we receive guidance from our consultations, it will help us become more confident in managing common conditions. And then it also will then increase the capacities, the system's capacity for providing care for children. And then it will improve outcomes for our patients. We know that earlier intervention, better informed decisions, and continuity of care can all lead to better outcomes for children and families, fewer crises, and then also a stronger trust with the healthcare team. Next slide. So this slide outlines how OPPAL can seamlessly fit into a typical clinic workflow. And putting this together, I did consider my own practice, which again is in a school-based health clinic, but also a primary care, more traditional practice, which I have experience in as well. So the first step is to identify a mental health concern. And so this could be anything from anxiety to depression, behavioral challenges, or medication questions. At that point, then you would determine the appropriateness for OPPAL. It's intended to support non-emergent mental and behavioral health concerns where guidance from a child psychiatrist would be helpful. Once you've determined that this would be an appropriate case, I then explain the process to the family. So I will explain that this is a consultation service. We do not use any patient identifiers and making these calls. And that, explain that this is a program to help support us in caring for their child in a primary care setting. We then, the next step would be that we contact OPPAL. The phone number is there on the screen. We can then, as the provider requesting the consultation, can request a call back at a time that's most convenient for us. So if there's a time later in your day, maybe you have some admin time, or your last patient scheduled for 3:30, and maybe you're going to have time at the end of the day, or maybe you have time right then, you can request a call back. That it just depends on your clinic flow. At the time which you speak with the psychiatrist, you want to give a brief clinical summary, including the patient's age, the presenting concern, any relevant history or current medications, and then the specific clinical question that you're hoping that they can address. And then the final step would be to document the recommendations in the EMR. And I'll talk more about that on a later slide. But you want to document the recommendations and then incorporate those into the patient's plan. And the goal of this is really to make this process efficient and practical and easy to navigate so that we can incorporate this into everyday clinical practice. And with the experience I've had, it has been just that. It has just been so easy to use. It's been such a blessing to me in my everyday clinic. So next slide, please. So I actually have a few sample cases. I'm going to just run through the first one and then move through my next few slides. And if I have time, I'll go back and run through a couple other samples. These are real cases that I have used OPPAL for. So the first case here is a 16-year-old female with a 1.5-year history of treatment for depression and generalized anxiety disorder, including both school-based mental health therapy and pharmacotherapy. Despite the ongoing treatment, the clinical assessment remained challenging. There were frequent inconsistencies between her clinical presentation, her self-reported symptoms, and then the standardized screening tools that I would use, which made it really difficult to determine kind of the next steps in my management. During a phone conversation with mom, she had expressed concern regarding the possibility of bipolar disorder because the patient had started to exhibit some increased irritability, which then added another layer of diagnostic uncertainty for me and can increase both the patient and the mother's anxiety surrounding her health. So I had previously referred the patient to psychiatry, but an appointment was never made, and this was on behalf of the family. And I think I imagine this is not uncommon. And it just I think it highlights sometimes the barriers to access care. So this, in my mind, this was a great case for OPPAL, where they could provide some timely psychiatric guidance for what I needed to do, helping me clarify the diagnostic considerations and what to do treatment-wise. So I made the call, spoke to a psychiatrist. The information and guidance was wonderful. We talked through some additional diagnostic considerations such as ADHD, Even autism was brought up as I kind of described some of the patient's behaviors and mood challenges. The psychiatrist suggested some additional screening tools, some of which could be found on a website called Psychology Tools Today. That was a new website to me. I had never heard of that. So it's a great resource that I now have in my back pocket when I need it. And then the psychiatrist was able to help me determine the appropriate next steps. Unfortunately, for this particular patient, while we had all these recommendations, they did not follow through with the recommendations to complete the additional screening tools that I had asked them to do. But fortunately, she was able to get into psychiatry with some additional prompting. But what came out of that consultation for me was it just kind of expanded some of my diagnostic considerations for this patient should somebody else present similarly to her. And as I already mentioned, it did kind of open my eyes to some additional resources, including that website that I mentioned. Okay, so if we can go ahead to the next slide, I want to talk about kind of the documentation, and then I can get back to some additional cases if we have time. So once a consultation is complete, again, it is important to document the consult in the EMR. I think the easiest way to do this is to create some type of a smart phrase or template that will just keep your documentation consistent and efficient. For me, I created a dot phrase that's pretty simple. It's titled OPPAL Consult Note. I actually just plug this in to my my encounter for the day. And then it has the date of the consult, patient's name. I put who the consultant, the provider was, and then I list the recommendations. After those recommendations, I list my plan, and then I have basically just a drop down, just yes or no, if that, if I had already discussed the plan with the family. So I put that in my clinical note. And so, in doing that, like I said, when I put my recommendations, I do just summarize the psychiatrist's key recommendations, including any diagnostic considerations, medication changes, or referral suggestions. And then outline my next steps, any adjustments to therapy, referrals to specialty care, or my plan for monitoring and follow-up. Okay, next slide, please. All right. I think in order for OPPAL to be used effectively, it's important to teach the clinic staff about the program. So it shouldn't just be the providers. So your front desk staff, any nurses or medical assistants, care coordinators, everybody plays a role in supporting this workflow and helping providers access the service when needed. I think, a simple but effective step is just placing the phone number somewhere right alongside other phone numbers that you commonly use in clinic. So in my case, being in a school-based health clinic, we have a very small team. So for me, I just have the phone number listed with other common numbers, just kind of taped to the side of my computer. And that just helps me remember that resource is available. But I'm sure in other offices you could put that anywhere, where you keep your other phone numbers, phones around the clinic. And that just makes it more likely that a busy provider will use that, in real time during a very busy clinic day. And these just little, implementation steps can make a big difference in helping integrate OPPAL into your everyday practice. So with that is the end of my slides, although I do have a couple other cases. So I guess, Kristen, where are we on time? Should I go through a couple other cases?
I think we have a few minutes, and we also did have a question in the chat that I think we could address now. So the question is, do you document in your chart that consent was obtained from the family to use the service?
So I do not. I don't. I guess for me, because I know I'm having that discussion with the family, and we're not using any, PHI when we're giving the case. I don't I'd be interested to see if anybody has any thoughts on that, but as of right now, I do not.
All right, and I think with that, we do have time if you wanted to talk about maybe one more case. I think then we can toss it to the next presenter after that.
Absolutely. So, another case where I used OPPAL was with an 8-year-old male who was diagnosed with ADHD about a year and a half ago. He was originally started on an extended release methylphenidate and was doing pretty well on that, kind of hit or miss. Family wasn't the greatest historian. I should say mother wasn't the greatest historian. But in August of 2025, we decided to change him to an amphetamine. And so switching him over to Adderall XR. And that's just because the child, he was finally of age where he could verbalize how he felt, but he didn't like how he felt on the medication. And I didn't feel like there was as much clear benefit as I would have liked to have seen. But then following that, at his next follow-up visit, I noticed that he had developed a tic. It was mainly eye blinking. And mom, when I pointed it out to mom, she's like, yeah, I've noticed that over the past couple months, and we seemed to realize it was kind of directly correlated with the change in medication. So I consulted the OPPAL line mainly for guidance as to whether I should discontinue the medication he was on and switch to something different, or possibly add guanfacine to his treatment. And so it was great. We were able to talk through the options of what to do in this case. I learned that I could use a different amphetamine product and it wouldn't necessarily go on to create, or the tics might not continue, or that I could add guanfacine if I needed to. So it gave me some great options to then go back and, have these conversations with mom and make sure that, I weighed her, what she was interested in doing as well, and making my decision and plan for this patient. So it has been just a tremendous benefit to me and my practice. I've had the option or the opportunity to use it a few times. As you can see, I have some other cases as well. So I want to strongly encourage all of you to do it, because it's very easy. It does not add much to your day. It really, and for me, it takes away some of the stress of dealing with some of these behavioral mental health concerns in primary care.
Wonderful. Thank you so much. And I do just want to highlight a couple of questions again that were in the chat. One that was answered there, but everyone may not have seen it. So the question was, are patients billed for this service? Haley chimed in and answered, no, there's no cost for patients or providers to use OPPAL. And then our next question that we have in the chat is, do practices need to meet certain criteria to join OPPAL? And I'll let Haley or others chime into this, but I don't believe so. As long as you have, as long as your practice has prescribers there, I think that you are able to sign up for OPPAL.
I will chime in and second that. The criteria is really just a primary care provider or practice with prescribing abilities. And that's all we're really looking for to ensure OPPAL can be utilized by as many as possible in Ohio.
So great questions. And we will now move on to our next presenter.
Thank you, Kristen. Hi, everybody. I'm Malika Amini. I'm the founder and CEO at Trait Health, and I'm very excited to be here today. Trait Health is a patient-centered, clinician-directed technology platform in behavioral health. We optimize care coordination, better workflows, data quality, and provide insights to behavioral health specialists to deliver personalized evidence-based care to their patients. And we're just basically founded on 3 key principles. One is to enable early intervention. The second one is whole patient health, hence our relationship with the PCP programs. And the third one is to be really more on the measurement-informed care. So we're in consultation programs such as OPPAL, but we also have a very deep direct intervention capability that works directly with psychiatry clinics that are delivering care to patients directly. I am a cognitive scientist and an engineer by background and have spent over 30 years in healthcare, health tech, with mental health and behavioral health in general being the majority of those years for me. And I got hands-on involved with trait health as a result of a personal experience. It's not just my academic background or professional experience, but really a personal connection to this. And as a result, our company is built as a mission-driven organization and is really trying to improve access to care in addition to providing the types of measurement-informed care supports that we have, that we deploy our technology in. We are today deployed in 18 psychiatry access programs in perinatal, pediatric, and substance use within 7 states. So we definitely have a broader overview of how the programs are and sort of supporting multiple different configurations of these programs. Just as a background, we deployed initially, this is the PCP portal journey. We deployed initially as just a behavioral health platform. So we were in the behavioral health clinics supporting the consultation. So call comes in from PCPs, and we manage the entire workflow from the moment the call came in. And also separately on the enrollment side. So the behavioral health specialists or their admin programs would enroll the clinics and the PCPs on the trait platform. So when a call came in, they were identified as an enrolled PCP, or the person on the call was able to enroll them on the portal. Someone would document their triage of what the consultation was about, would submit it electronically to what is a consultation dashboard. And the psychiatrists or behavioral health specialists would be notified of the incoming consult and the callback time. And then the callback would be, clearly documented. The consultation would be documented on the trait portal. And it also had the ability to document any care referrals or care coordination information. So all of that consultation, recommendation, care coordination data would be documented on the trait portal. And then at the end, the behavioral health specialist was able to rate the complexity of the consult, the comfort level of the PCP with the topic or with the recommendations, until the call was considered complete and archived. So it was the entirety of the workflow was actually inside of the behavioral health hubs after the PCP had called in. One of the things that we actually noticed, because we are in a broader number of states and have a bigger overview of, what the programs are doing differently. One of the things that we identified very quickly, and data was a good reason for this. One of the things that was our benefit was we could take structured data on engagement, on consultation details, and be able to really provide the types of insights that would not only measure program health in general in terms of growth and PCP engagement, but also would enable the program to analyze the types of consultations, the types of recommendations, and even the types of referrals that were being made. But one of the things that we did notice was that even though as compelling as the program was, that one of the things that we noticed is that the engagement of the PCPs was not consistent at all. So there was enthusiasm, there was a lot of excitement about the program, but we noticed that across the country, consistently in all of the programs, we saw sporadic engagement from PCPs. There were definitely concentrations in the clinic types that were engaged, and and there were some very engaged PCPs and those who just did not engage at all. So there was definitely some inconsistency in that as well. We had several hypotheses for why this was happening, considering the different configurations of the programs, the different cultures within the states. We developed some hypotheses and then initiated a series of interviews at a national level with PCPs that were highly engaged, and then PCPs that were not engaged at all. But all of them enrolled. So they had all enrolled in a program within their states, but some of them were engaged at a high level, and many unengaged completely, never called into the program. So then one of the few things that we found out from the conversations. But in order for us to really validate our hypotheses, we needed to understand what the mental health support needs were. Were those unengaged PCPs unengaged because, for whatever reason, they either had a resource in their clinic or did not have the same level of need as others? We wanted to obtain feedback on the experience they had on the consultation service for those who were engaged, to really learn from the engaged members what are some of the things that even programs could use to encourage others to actually be more engaged. We looked to identify reasons for lack of adoption of the program altogether, and then for those who had called once or twice, why they were not calling more frequently, validate if, and then one of the things that we came up with was if they had other tools, if PCPs had a different tool, if they didn't have to just make a phone call, would they be more engaged? And then come up with different versions of what would help support the engagement of PCPs. We can move to the next slide, please. Thank you. So one of the things that we found out, actually we found out several things. The first one was that even though the enrollment of PCPs and clinics was actually highly successful, so the states were showing increasing enrollment and at a fairly consistently rapid pace, especially at the beginning, few months of the program. That the enrollments were very successful, but the engagement with the program or the program adoption by PCPs were less successful than the enrollment. One of the things we found out was that there was one person typically within the clinic that enrolled the clinic or attended a training program that resulted in the enrollments, but that the PCPs themselves were not always notified of this enrollment or of the program benefits or when and how they should be contacting the program. So for the most part, the unengaged, a very large percentage, were either not aware that they were enrolled in the program, or if they were aware that they were enrolled, they really didn't know what the program did, so never really looked into calling the program. They just had no idea. That was definitely one very large reason for unengaged PCPs. The other one was time. For people who knew, for PCPs who were aware of the program, they just felt like making a phone call during the day and coming up with a time for a callback and being consistently, on task with this call took away from clinic time that was already very busy. So they felt like they just couldn't find the time within the business day to contact the program and to share sort of this detailed overview. So there were many different ways they actually had addressed this. They started, compiling them together and, trying to get the call in one day for multiple patients, a number of different paths where they were taking. But at the end of the day, it became a challenge for them to actually use the program. As a result, we came up with an idea for the program and suggested it to one of our clients initially as a pilot program, was to create what was a PCP portal. So to provide the PCPs with a tool where they could put in a consult request electronically at any time during the day or evening even, from anywhere, since we're a cloud-based application, and to define or determine the callback time as if they're making an appointment, to say, please call me between 10 and 2, or whatever the time frame was. And then to also enable the PCPs to be able to electronically track where the consultation is, instead of having to call the program back every time to say, I haven't gotten a call back, or what was the ultimate recommendations of the program. Or even if there were tools, like, for example, screeners were often recommended in the program. We are a measurement-informed care platform in general, and so we have a library of screeners. And the screeners were being recommended, but the PCPs had to go and find the screeners, or someone had to ultimately email them a copy of the screener. And we were able to create the PDF version of that screener, especially for, there's some programs are no PHI, so they had and OPPAL is one that actually has a PDF version of the screener that gets submitted through the portal. So they don't have to search for it, they don't have to, and all of the information about scoring mechanisms are all included. So that really gave the PCPs not only an education level that was, sort of beyond a phone conversation of what the screeners are, but also tools they can use going forward, even without making a call into the program, which is ultimately the goal, is not for them to continuously call about the same thing, is for the programs to start to have more complex problems coming to them, and PCPs having the education and the tools in their clinic. So these were some of the things that we identified. One of the other items that came up was tracking their CMEs as it related to their PCP engagement. PCPs attended CME courses or educational courses that were offered by the program. So being able to track that through the portal was another item that came up from the PCPs when we were interviewing them. We can go to the next slide. Thank you. So we did actually incorporate all of these. E-consult request form is what has been incorporated. That PCP portal is live now. We did run a beta test in the state of Texas, which is our largest state deployment. Obviously due to size of the program, but also because it has been longest on the program in general for using trade. So we did do a beta release with them and received extremely positive responses to the portal. And they have seen already some, on the beta users for sure, they've seen engagement beyond what the average engagement of the program has been, significantly beyond that. So what we have incorporated is the e-consult request form, so PCPs can submit a request electronically through the portal. The portal sits behind authentication, just because there is, no matter how much, even if it's a no PHI program, there's always some detail included that, that needs to be protected with two-factor authentication, like any other PHI program. So they will have the e-consult request form. They submit the request form. Triage happens on the consultation side. They would review the request that has come in, make sure everything is included. Then they submit it electronically. The consultation will happen the same way. So the psychiatrist will call the PCP back. There is a conversation. And then the consult summary can be provided through the portal. And shared across the portal. Screeners are recommended in the portal, and the PCP receives a PDF version of that screener. For OPPAL, it's a PDF screener. For some of our PHI heavy programs, they actually receive the actual electronic screener and can be scored electronically, but the capabilities are, varied across different programs. They also will have a dashboard of data about their own consult activities. So how many consultations, how many of them are still live, how many are active, how many have been, and then, data around, this is something that we also provide. It's called key metrics to the behavioral health programs, but a mini version of that is going to be available. It's under development, but it will be available to the PCPs once this has been deployed. The analytics have been deployed, but they basically get they get a streamlined workflow and electronic communication through the portal. And again, we've seen this is now deployed in 3 of our states, including OPPAL. And the hope is for us to compare engagement before the PCP portal and after, and provide that kind of data to the marketing and outreach teams within the programs in order to even increase the engagement with the PCP portal itself, and the deployment of the PCP portal. We can go to the next slide. So this is, again, I already described this workflow, but there is obviously a phone consultation. PCPs have an option to still make a phone call into the program and request a consultation, as they have always in the past. And then there is a PCP portal option, Any PCP can choose to create an account or not create an account. They all get invited to create an account. And then they can submit their consult electronically, request electronically, and be able to receive a callback at their desired callback time. But that's basically, this workflow is what I was defining for the most part. And then everything gets recorded on the trade portal. We provide a number of different tools for behavioral health specialists to not only look at key metrics, which is general program health at an overview level, but they can also export and download several other reports on enrollment, on consultation details, onto CSV file directly from the portal for further analysis by their own evaluation teams. Yeah, we can move to the next slide. Thank you. So this is the value of the portal has been beyond workflows. Obviously, workflow is definitely a component of what is streamlined in order to reduce the cost of the program in terms of managing the workflow, managing the data, and to make sure that the majority of that budget is spent on providing actual care and services to the PCPs. But there is definitely some value in the data that the behavioral health specialists are receiving, structured data on de-identified patient health history, where they can look at the clinical recommendations, care coordination outcomes, and really analyze that for improving consult quality at the end of the day. Measurement of the consult complexity, so the evaluation at the end of this process actually tracks PCP comfort level with the recommendations, with the behavioral health topics that they're coming in with. And then over time, they can measure if the complexity of the consult requests are increasing, which we have actually seen a national trend that PCPs are calling in with more, within those states are calling in with more complex problems, indicating that the problems, the simpler problems are now being solved within the PCP clinic without the need for a consultation. So there definitely has been positive trend. And then PCP adoption rates and engagement with the program. That's something that obviously was a key, kind of a core part of why programs need a technology, is to measure the engagement. And so we've been able to track that engagement levels. We also have engagement tools where they can market and target PCPs, do campaigns with educational content or with different types of marketing events. But those are the types of things that we provide for them. Based on the data, they can actually target and tailor some of the messaging even to their PCPs. We can go to the next page. And then the same thing for PCPs. As I mentioned before, there is, obviously one of the key components of why we incorporated the PCP portal was in fact for streamlining workflows. I mean, it was, there was definitely a workflow component of not being able to make the call during the day for every patient that came in with a behavioral health need. So we did address that, but there definitely is a lot more involved with the PCP portal that provides the PCPs with the tools that they need, but also really, really takes the program quality and the, kind of meeting the vision of the program at a much higher level by providing them the evidence-based standardized screening tools, for example, or the dashboard that could help them even track their consultation progress. Insights for PCPs to see how their own consultation compares to their own program or to the clinic itself, and then curated content. One of the things that is currently under development is a knowledge hub where PCPs have all kinds of content and topics and tools that they could identify on their own, even if they're not making a call for any consultation reasons. I think that is my last slide. I'm happy to answer any questions.
Thank you so much. Great information. And just a reminder, as we just have a minute left, this is the slide to help you with enrolling for that 50% of you who aren't enrolled. I wanted to ask Dina, there was a question that came in the chat. Do you call to speak to a specific hospital team on a specific day, or do you call depending on when you see the patient? This was a question that we had come in the chat, in a chat.
Yeah, I call just whenever needed based on when I see the patient. So I'm not calling a particular hospital.
Perfect. Thank you. And then if you didn't, there are some questions answered in the chat just in terms of if you're not a primary care practice, if you're a subspecialty and you are seeing children and adolescents, you absolutely can enroll in OPPAL. While OPPAL does prefer that the provider actually be the person to call, if an MA or nursing staff has all of the information that's needed, they can initiate that call, I believe was the other question that was answered. So we are at 1 o'clock. If there are any other questions, if you could ask those quickly, because I know I do want to be mindful of time. And then just thank everyone for joining us today. Please remember this is a webinar series. I think most people who are registering for more than one, but if you only registered for this one, please be sure you take a look at the other webinars that we have coming up roughly every 2 weeks or so up through the spring. So thank you again, and we will send out a follow-up email with the recording and slides.